this is to end in fire, then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over and on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, calling out, Father, oh, prepare as we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees, and I see fire hollow and soul. I see fire blood in the breeze. If I hope that you remember me. Surely I'll do the same. Come finding mountain holes. We got too close to the flame. Calling out, Father, oh, hold fast and we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire.
Welcome everyone on to another series on their webinars with GDR. Myself, Daniel, really excited tonight to present to you Dr. Davey and David. We're very fortunate to have the duo here with us on biomimetic dentistry. It's a term that gets thrown around a lot these days. What is it? What's it about? How does it kind of go and lend towards what I think almost every dentist out there is doing, and that's sort of restorative dentistry. So we're really excited, really fortunate. We've been working hard behind the scenes to make this all happen. So if you haven't already, if you like us on Facebook and Instagram, we really appreciate that from myself and Daniel. And we're really fortunate again to be sponsored by Morden. We've got Kane here with us. We'll be doing a bit of a Q&A with Kane later on, just before the Q&A, kind of similar as to what we've been doing last time, and hopefully give people a bit of an idea of where Morden can fit into your daily practice and getting into implants and what you can do right now, kind of online and what's available. So Dr. Davey and David Alleman, they've been, firstly, got to take note, they're from Utah in the US. It's 3:30 a.m. right now, 3:45 a.m. right now there. So they're on 1 hour of sleep, a few American pop drinks, and they're good to go. So we're really, really fortunate to have them here with us. And so both of them together have really been kind of father and son, and also kind of progression of biomimetic dentistry and bonding protocols, up there with the Pascal Magnes of the world in delivering. And they have a biomimetic workshop and master program that we'll have links to as well if you're interested. You should definitely follow Davey on his Instagram. He should post a lot of really interesting cases and practical stuff that we do every day and that we can all kind of strive towards. So quick housekeeping. We'll have the talk in a moment with both the doctors. Then we'll have a quick Q&A, and then at the end, then we'll have a little section with more dent, and then we'll go into Q&A. We'll try and get through as many questions, so please keep them going. I'll be sending any questions that I can't answer onto Dr. Davey, and we'll get them answered for you somehow through social medias or whatever it may be. So make sure to hang around till the end. That's when we'll be posting the login and the link for the CPD certificate. That'll be under the comments section. So make sure to hang around until the end. CPD certificates will be sent out usually by the end of the week. So we get a lot of messages about that. So don't worry, it will come. Without further ado, please welcome Dr. Davey and David Alleman.
Well, we're really glad to be here. This is very early and not quite sunny Utah. It's pitch dark outside, but we are wide awake and we're excited to spend this hour with you today. So if you have questions, we'd like you just to put those in the chat below, and that allows us to kind of review them sequentially as the questions roll in. But I want you to think about what the biomimetic number is. Biomimetic is now becoming a very buzzword. Many practitioners are using this as a way to get patients into their chair, saying that they do something, but they may not really have a firm grasp on what biomimetics is. Just like not all cosmetic dentists are the same, not all biomimetic dentists are the same. And throughout the world, many dentists have had to adjust how they practice due to the coronavirus and the restrictions from many state, local, and federal government agencies that have been placed on them. But I want you to think about the last month that you were practicing in some kind of regular capacity. And I want you to think, in that month, how many teeth did you cut down for a full coverage crown? Once you have that number, I want you to scribble that down on a piece of paper. And then after that, I want you to go back the month prior and recall how many times did you cut down a tooth for a traditional full coverage crown where it's relying on retention rather than an adhesive approach. And I would hope that the previous number is less than the last number that you thought of. Because as a true biomimetic dentist, the biomimetic number would be that of 0. A biomimetic dentist never cuts a tooth down for a traditional crown. I'm going to say that again. A biomimetic dentist never cuts down good tooth structure for the sake of retention. When I was in dental school, I had a very, very good friend. His name is Raleigh Smith. And he was one of my classmates that I could bounce ideas off of. He didn't fully ascribe to what he was being taught in dental school. And so he kind of gravitated to some of my leanings as a future biomimetic dentist. But he asked me, he said, Davey, what is the only reason that a dentist would cut a tooth down for a crown? And I'm jaded, because how could I not be jaded? This legend that is my father had ingrained in me how bad it was to cut away tooth structure just for the sake of retention. But I just said, Raleigh, the reason why a dentist would cut a tooth down for a crown is because they make a lot of money cutting teeth down for crowns. They make a lot of money by doing the endo. And he said, Davey, you're a really smart guy, but right now you've got the wrong answer. The only reason that a dentist would cut a tooth down for a crown is for retention. The only reason that dentists would cut a tooth down for a crown is for retention. And that's because they do not have the tools to predictably bond to a non-retentive prep. Now, with biomimetic dentistry and the techniques that we go in great detail in our mastership program, we teach you protocols and the science behind the techniques so you can predictably take a preparation like you would see on the left, where the tooth has had a root canal. The tooth has very minimal tooth structure after the caries removal endpoint is formed, and predictably preserve the remaining good tooth structure and have an additive approach. This case was restored with a semi-direct technique, which was done chairside same day. This is just one strategy that a biomimetic dentist can use on a daily basis without the need of a CEREC machine, a high-end lab, or the monotony or the tedium of doing it all with a direct technique. But basically, this tooth is now connected side to side, top to bottom, and front to back. And so when this tooth is under function, it actually bends and flexes like a natural tooth. Biomimetic dentistry, you have to know the biomechanics of what you're trying to replicate. If you do not, then you do not know your goal. If you don't know your goal, if you don't know what you're shooting for, it's very hard to mimic. And so biomimetic dentistry mimics nature. It mimics the natural tooth, and that is the goal. And these are two biomimetic restorations that my father placed. I'll let him talk a little bit about it.
Yeah, 20 years ago, actually, the patient is coming in tomorrow for photographs, follow-up photographs, almost 20 years, full mouth construction with biomimetic dentistry, no retention form, no resistance form, just composite bonding, highly bonded, and longevity. 20 years for a crown doesn't happen that often, but for biomimetic restoration, we're seeing those every month.
So with biomimetic techniques, you can preserve the maximum amount of tooth structure for your patient because you are maximizing the bond strength of your restoration to the tooth so the tooth bends and flexes like a natural tooth. But I want you to think about the last tooth you fixed. And I want you to think about all of the small little steps that you took along the way, and if you could tie it back to the science. Because on a daily basis, dentists are confronted with teeth in a very similar situation as this, where a patient knows they've got a problem. A portion of the tooth is chipped away. It is currently asymptomatic, but they want to be proactive. What is your treatment approach on a tooth that is fractured a cusp? How are you assessing the decay, and how are you preserving the vitality of the tooth? Now, when you take the image on the left, the first thing you should be thinking is, how do I have a highly bonded preparation without exposing the nerve? And the paper that you should tie that back to is a 2012 paper by Dr. Alleman and Dr. Pascal Monnier, a systematic approach to deep caries removal endpoints that outlines a predictable technique so you prevent unwanted pulp exposures in deep carious lesions, and also an ability to read the hierarchy of bondability of the prep. Once you have your caries removal endpoint, you now need to know how to seal the tooth so you can mimic the DEJ and maximize the bond strength of the bottom half of the bottom of the tooth to the enamel replacement. And how do you do that? That is through immediate dent sealing. So if you don't have the paper from 2005 in the Journal of Prosthetic Dentistry by Pascal Monnier, where it shows that IDS increases bond strength 400%, then you may be confused on what you need to do moving forward. After you've done immediate dent and sealing, you need to make sure that there is a resin coating, especially if your adhesive isn't as thick as Optibond FL, which is 80 microns. The adhesive that we prefer is SC Bond or SC Protect, which has a thickness of about 40 microns. And so you need to have the paper by Pramali Jayasuriya that talks about resin coating and the benefits of that, where you actually place a thin layer of flowable over your immediate dent and sealing. We then go on to how do we create our biobase? And then how do we bond our enamel replacement to our pre-cured bonded preparation? And with these papers, you can understand and predict how to fix this tooth so it'll stay bonded long term, and you'll have a connection top to bottom, side to side, and front to back. So the idea of why do you do anything? This is a very great read by Simon Sinek where it says, start with why. And this quote by Michael DeGrange says, the general practitioner and specialist alike are confronted with a mass of raw information, neither sorted nor put into a hierarchy, and often contradictory. Adhesive dentistry still requires sophisticated procedures, which are highly operator dependent. However, the potential high quality results possible with adhesive techniques justify the special effort required. Anytime that you read a piece of dental science or dental research, sometimes it is very difficult to apply that into the daily practice. And that is because in order to learn something, you have to have a framework in order to integrate this new knowledge into practice. And so when my father was beginning his quest in the early 2000s, training dentists in biomimetic techniques and in biomimetic dentistry, he developed what is called the 6 lessons. Now I want you to take a picture of this slide. This is the easiest way to get any of your questions answered, either through Instagram mainly, where you can just instant message either my father or myself about any questions or concerns you have regarding this presentation, or if you would like to have further mentoring and training through our mastership program. But by starting with why, my father developed a very important framework called 6 lessons, which allows a dentist to put into a hierarchy the most important thing to fix a tooth biomedically to the least important thing. All of them are important, but lesson 1 is more important than lesson 2. Lesson 2 is more important than lesson 3. Lesson 3 is more important than lesson 4, and so on and so forth. And you can find more information at our website, drdavidalleman.com. It's very easy. But basically, we do a weekly training with 10 to 12 doctors over 9 weeks, where we go into each of these lessons in great detail, and we give you anywhere between 12 to 19 pieces of literature to read each week that really cements the techniques to the science. And by knowing the whys behind the technique, you're much less likely to be swayed when a sales rep presents you with a material that may not have the best scientific track record, or a key opinion leader talks about a technique that has
It's easier,
faster. Biomimetic dentistry is not an easier nor a faster way to do dentistry. The claim that we make is it's the best way to do dentistry. And so both me and my father were both very avid golfers. And I want you to just talk about how you developed 6 lessons. And
if you're not a golfer, you don't know who Ben Hogan is. If you are, he's like one of the golfing gods. He wrote a book, classic book in the 50s, 5 lessons. So this is an homage to Ben Hogan. If you have a system, you're going to do better in golf. If you have a system, you're going to do better in biomimetic dentistry.
And so when we say 6 lessons, it's giving tribute to one of the best golfers in all of the world,
Yep.
in all of the history of the world.
Yep.
Ben Hogan, he actually won golf tournaments after being hit by a bus.
Major golf.
So the hierarchy of importance is 1, diagnosis and treatment of caries, 2, diagnosis and treatment of structural compromises, 3, immediate dent and sealing and resin coating, 4, C-factor control by decoupling and fiber placement, 5, enamel preparation and onlay design, and 6, occlusal adjustment. Many young dentists will think that the most important thing that they need to do right out of dental school is to get occlusal training. We would say the exact opposite. The most important thing for a young dentist is to learn how to fix a single tooth correctly the first time. And to do that, you have to start with caries. Most dentists feel like they're very adequate and proficient in dealing with the diagnosis and treatment of caries. But unfortunately, when I'm on social media, I would say it's one of the least well understood areas in dentistry, and it causes problems on a daily basis. So what is biomimetic dentistry? A biomimetic restoration preserves the maximum amount of tooth structure where we don't have infection, cracks, and we have a highly bonded restoration that acts and mimics that of the natural dentition. 2 of the main leaders in this movement over the last 2 decades is Pascal Magnier and also my father. They've had different paths. One was university trained that Pascal was fortunate enough to have, and the other one was a private practice model like my father. But both of them followed the science very precisely and were following a lot of the same researchers and came to the conclusion that there is no reason to cut a tooth down for a crown. And that's because the biomimetic principle states that the idea that the intact tooth is the guide to reconstruction is in sharp contrast to the porcelain fused to metal technique, in which the metal casting with its high elastic modulus makes the underlying dentin hypofunctional. So this is the foreword in the 2002 paper, and that was by William Douglas, that quote. But the idea that a very stiff crown, like a zirconia crown or a PFM crown, the tooth, when it's under function, does not bend and flex in a cohesive unit. It'll actually have the underlying dentin not move, or in other words, be hypofunctional when the crown is being chewed upon. So the crown will move one way, but the tooth below will not move in the same direction. And this allows for micro gaps and recurrent decay, just like you saw with this extracted PFM, where because the dentin was hypofunctional, decay was able to occur in the
This is one of my failures before biomimetics. This is what drove me to biomimetics, because I hated these failures. I was a dentist for 17 years. I quit dentistry because I hated these kinds of failures. But then I found out about adhesive dentistry from Japan. And then I started a quest to find out if it could really connect the tooth side to side, front to back, and top to bottom. And it can.
In the last 20 years, you haven't had a failure like this.
Never. Never.
And that's because the biorim, which is the cervical area of the tooth, absorbs the forces of occlusion. This paper in 2002 did a finite elemental analysis, and you can see where the forces of occlusion during both working and non-working movements, that the forces are generated right at the margin of where a crown would be placed. And this is also something you can link back to the failed crowns that you are replacing. Where does the decay usually form? Right at the base of the crown margin. And so if you can preserve the biorim, which is this cervical third, you are actually keeping the tooth's natural defense mechanism to resist the forces of occlusion. And when we look at a tooth, the tooth is not a monolithic structure. It's actually a
Trilaminar.
a trilaminar material where you've got a stiff enamel shell, which is highly mineralized, protecting a very tough, more flexible dentin core. And this perfect union is connected with by the DEJ or the DEC, which is the tooth's natural adhesion of two very different materials. So you have enamel on the outside and dentin on the inside. And this team of researchers out of Japan in the early 2000s started measuring the tensile strength of the DEJ region, and they measured it right around 51 megapascals. And at this time, they were also studying the tensile strength of the adhesives that were coming onto the market. And this is when Liner Bond 2 was coming out, SC Bond, and they found that novel resin bonding systems have the tensile and cohesive strength of the DEJ region. Accordingly, these materials have sufficient bonding performance. Therefore, new principles for restoration should be established. And so if you can have your adhesive have the similar tensile strength as the DEJ, then why are we cutting teeth down for a retentive preparation if our adhesive can be as good as the natural tooth? But unfortunately, in order to mimic the tensile strength of the DEJ, there is no simple way. The researcher that is standing next to my father is Bart Van Merbeek. Very few dentists know who this is, but he is the world's leading expert on testing adhesives, both in vivo and in vitro. And he says, an adhesive restoration has many advantages over conventional non-adhesive restorative techniques, except that it cannot be yet realized in a simple way. So many times when you are confronted with a class 1 restoration and you think, finally, I have an easy restoration to fix, that should be a red flag. As soon as you say, oh, this is an easy thing to do. Oh, there's a material that makes this very, very easy. I've got a simplified adhesive. I've got a universal bond. I've got a bulk fill material. Unfortunately, anytime that you are simplifying the process, you are compromising in very critical areas. And we will go over that in these 6 lessons. But first, we need to start with the foundation of a biomimetic restoration. And it starts with the diagnosis and treatment of caries. One of my favorite sayings is that biomimetics isn't a top-down approach, but it's rather a bottom-to-top approach. I can tell how well a dentist is trained by how well they treat our most important professional duties, which is that of decay, treating decay. And so the idea of a peripheral seal and a caries removal endpoint that prevents pulp exposure should be the goal. If you have if you've created a direct pulp cap, you have made a mistake, because even with infected dentin, there is a bond strength that you can achieve as long as you allow that to mature in a stress-free environment. But if you remove all decay and cause a pulp exposure, you have tripled the likelihood of the tooth needing to have a root canal. So this diagram on the left was one of the early diagrams that illustrated this idea of a peripheral seal zone before the 2012 paper was published. But the goal is a highly bondable, caries-free peripheral seal zone with reproducible caries removal endpoints without a pulp exposure. I am perfectly comfortable bonding to each area of this tooth, because if I removed all stain, I would for sure be having a bleeding tooth. And if I have a bleeding tooth, I've made a mistake. When we go into lesson 1 in our mastership program, we talk extensively about understanding that this has a different bond strength than the pink, and that the pink has a different bond strength than the red. But if we can have a very highly bondable peripheral seal, we can protect these weaker bonds in the center of the tooth. In order to create the peripheral seal zone, we have to know the measurements of the tooth. We need to know that it's about 6 millimeters to the pulp. Superficial dentin is about 1 to 1.5 millimeters. Intermediate dentin is 1 to 1.5 millimeters, and deep dentin is also similar to that. So there's a gradient, and each area of dentin has a different concentration of dentinal tubules, and also the size of the lumen is quite different from deep dentin to superficial dentin. And by understanding this, we can pick an adhesive that prevents some of the complications of increased pulpal fluid in our hybrid layer and these sort of complications that dentists are confronted with on a daily basis. But the first thing we need to do is we need to know when to stop. So by measuring, we can prevent unwanted pulp exposures, even in deep carious lesions. And in the paper in 2012, that number is we stop at 5 millimeters when we are on the inner portion of the tooth, and then 3 millimeters axially. And the way to create this peripheral seal zone, you need to first visualize the DEJ. Once you visualize the DEJ, then you can know where it is very safe to remove decay aggressively. And if you have the DEJ visualized, you can take a burr that is about 1.5 to 1.7 millimeters, and you can clean that area without running the risk of having a pulp exposure. And so in this area, we would want no red, no pink. It is very critical that if you are doing a biomimetic restoration, that you use caries detecting dye, because caries detecting dye allows you to know the hierarchy of bondability in a preparation. So here, first thing we do is we identify the DEJ, and then we take our burr that is about 1.5 millimeters, and we clean this area until it no longer stains red and pink, even after multiple applications. Now, this area where it is pink, because of the measurements, we are going to stop. This will bond at about 30% less than the peripheral seal area. And the area that is staining red, that will bond at about 60 to 70% less than the peripheral seal zone. But the benefits of not exposing the nerve far outweigh the weaker bond by not exposing the pulp.
In those inner areas, you just need a seal. You don't need strength. It's where the pulp used to be. There's no strength of the pulp area.
Exactly. But if you are leaving decay in the peripheral seal area, you are compromising the tooth as it's under function, and you will have a much higher likelihood of recurrent decay and possible pulpal necrosis. So here, showing the measurements of stopping at 5 millimeters.
The second instrument is approximating the central groove area, so you're measuring down from that. That's a nice
show that.
Yeah.
So you can see the perio probe is going along the long axis of the tooth, and then a flat instrument is being laid to approximate where the cusp tips and the central groove were once present. And once we have our peripheral seal zone and our caries removal endpoint, we can now seal in that area of decay, and that tooth will have some remineralization in those areas. And as long as we don't stress this bond too soon, we will have a highly bondable restoration long term. So that brings us to lesson 2. So we just covered a very small segment of lesson 1. We will also cover now lesson 2. This is structural analysis. This is the idea of what do we do when it's too big for a filling. But structural analysis begins with the idea that if a tooth is bending and flexing too much, it is more susceptible to cracks. And these cracks in enamel can lead to what we call occlusal effect caries. And this occlusal effect caries is not caused from a lack of flossing, but because the bending and flexing of the tooth is allowing a biofilm to form along the crack. And now we have a very symmetrical lesion coming from the inside. And that's because these peripheral fractures create 50 to 100 microns openings for bacteria to enter and replicate. And this case, you can see the occlusal effect caries very clearly, where you have demineralization on both sides of the crack. And the crack also extends well into past the DEJ and into the dentin. And so this patient, she was very symptomatic. She had a very difficult time chewing on her lower right side. I said, look, based off of the size of these restorations, my guess is you have a crack into dentin, and that this tooth needs to have some kind of partial coverage restoration where we actually address the cracks and bond the tooth so it starts to be bend and flex like a natural tooth instead of in two different directions. And sure enough, when we take out the old amalgam, we can see a crack of passing the DEJ and into the inner portion of the tooth. And this crack, we do not try and just bond over the crack. We don't ignore the crack, because this is what engineers would do. Engineers do not ignore cracks. If you ignore cracks, these cracks will continue to propagate under function.
Sensitivity
and
fracture.
Yeah,
It hurts.
Exactly. If you do not address the cracks, the patient will be uncomfortable. You would never leave a large amount of decay on a patient or a tooth that you are restoring. So why are we doing the same thing with cracks? It might be because your magnification is so low, you aren't seeing the cracks. We recommend that every biomimetic dentist goes to 6-power magnification, preferably with a microscope. But if not, there are very good loupes that you can get high magnification to visualize these cracks so you can actually dissect the crack and allow for the tooth to be restored in a biomimetic fashion. So if you bond over a crack, the crack will continue to propagate under the restoration during functional and parafunctional loading. And when this crack moves and begins to propagate, the patient will once again have symptoms where they're having intermittent sensitivity on biting. So these cracks can be removed very predictably, just like we do with deep caries, with the same measurements that we do with the peripheral seal concept. And so you take a round diamond and you clean the cracks out in the peripheral seal zone so there is no cracks. And once you have a crack-free situation, you can go ahead and bond it and create your foundation for your onlay, and then cement your ceramic or composite onlay in this situation. When we have our caries and crack-free foundation, we want to maximize or mimic the DEJ or the DEC region. And so we do this through immediate dentin sealing and resin coating. And this is lesson 3. Lesson 3 begins with isolation. It is important to note that every bond test is done with perfect isolation, typically on a bench top. So if you're using a bad adhesive and you say, well, because I'm using a rubber dam, my restoration is going to be good, that is unfortunately false, because when they're testing adhesives, they're testing bad adhesives against good adhesives, always in a dry environment. So we need to isolate the tooth, and we also need to use gold standard adhesives in order to maximize and mimic the tensile region of the DEJ. So immediate dentin sealing and resin coating needs very good isolation. The best is rubber dam combined with high magnification. And when we talk about gold standard adhesives, it is important to know that not simpler always outperformed the simplified systems. So Optibond FL would be a total etch system that we would recommend. It's a 3-step. And then Clearfill SE Bond or SE Protect or now SE Bond 2 would be the adhesives that would resist the hydrolytic degradation that most often affect those simplified adhesives, where they're combining very hydrophilic and hydrophobic chemistries, and there is a competition. And these are the adhesives that we use on a routine basis, and they will work very well even on your worst day. So with SE Protect, this is the adhesive that we use almost exclusively for a variety of reasons. But you would prime the dentin and enamel for 20 to 30 seconds, and you would air dry that for 10 seconds. And then go ahead and apply your adhesive. And instead of air thinning your adhesive, because there is no solvent, all you need to do is take a dry microbrush and wick away any pooling, because this will show up as a little bit of a radiolucency if there is pooling next to a band, and then you go ahead and cure this. So this paper that I referenced in the second slide of the 2005 paper by Pascal Monnier, it showed that immediate dentin sealing increases dentin bond strength 400% compared to delayed dentin sealing. This is because adhesives take time to develop, and it takes a lot of time when you're dealing with a very moist substrate such as dentin compared to enamel. Every one of us have heard a lecturer or a professor say the best bond is enamel. Unfortunately, that is not necessarily true. Enamel is the fastest bond to form because of its high mineral content versus dentin. But because dentin has this toughness, if you allow the hemahydrogel to encapsulate the collagen fibrils, you can actually get the toughness of the dentin, and that toughness will actually allow the dentin bond to be superior to the enamel bond if you allow it to mature in a stress-free environment. Immediate dentin sealing allows the hybrid layer to form in a stress-free environment. When we resin coat, there's a variety of reasons to do this, and that is because a resin coating will protect the dentin bond below. If we can have this idea of a secure bond strategy where we have a slightly weaker bonded interface at the flowable layer to our composite onlay or our next layer of resin, then when it's pulled apart, we can have a failure mode that is not between the adhesive interface. So a total bond strategy would have a failure at the dentin interface. This would cause a patient discomfort or sensitivity if there was a failure. In a biomimetic restoration and you have a proper secure bond, if there was a failure, you would still have this flowable layer protecting the dentin on the inside. And this paper showed that when they pulled it apart, they were unable to to pull off the onlay and expose the dentin, whereas when they did a direct approach, 100% of the failures occurred right at the dentin resin interface. And so even though this bond strength here is slightly less than this one, this failure pattern is so much better than this. And we can assume that this bond strength of 42.5 is actually still the same as this one, but there is a slight fail safe between the onlay and the flowable that protects the underlying dentin if there were to be a failure. And this combined with a layer of ribond or fiber underneath your restoration gives an added fail safe that prevents re-exposure of the dentin. And Semabelli is the expert in this field, and very few people know who she is, but you had a live with her just the other day.
500 people know who she is.
And so she is a researcher out of Turkey. And what she has done for dentistry is not only important, it is critical if you want to have a tooth that is staying bonded from the bottom.
Especially in high configurations. Lesson 4.
Mm-hmm. So lesson 4, this is by far the hardest lesson that we teach doctors, and it makes them spin. So I'm just going to give you just a very quick tease. We've just been giving you a little snippet of what we go into in this 9-week program.
It's a 12-month program.
A 12-month program, because we do
9 weeks intensive, and then
we do
12-month
mentoring
review.
But the idea that how a prep looks can really impact how well the restoration and the tooth are bonded. And so the idea of C factor, or the configuration factor, which is the ratio of bonded to unbonded surfaces, can dramatically affect the strength and the connection of your restoration to the tooth. And this paper by Toro Nakaido showed that in high C factors, you will lose up to 50% of your bond strength right off the bat. So a class 1 that is done quickly will have half the bond strength that your dental rep is telling you. And then when this patient is chewing on this for a year, 2 years, 3 years, it loses an additional 10% of its microtensile bond strength. And so if we said that the goal of a biomimetic restoration is 51 megapascals, but we use a simplified filling strategy, all of a sudden we are not going from 50, we're going from 50 down to 25. 25 is not a biomimetic number. If you're using a bad adhesive, maybe you start with 30 megapascals on a low C factor, and then you drop down to 15. How we layer is so critical. I'll let you go over this.
So this concept was developed and published in 1985, before many of these papers were written. And the material expert in polymerization dynamics in the world at that time and for the next 30 years was Carol Davidson, University of Amsterdam. And he said that if you do not understand C factor, you will decrease your bond strength, you will lose your seal, you will have infection and fractures. That's exactly what we've been saying for 30 years. But this paper shows that if you have a horizontal layering technique of 1 millimeter in a 4x4x4 preparation, you will double your bond strength. But they have to be 1 millimeter horizontal layers. And to get 31 megapascals is a biomimetic number, because the cohesive strength of the enamel is around 30.
And so you can take this principle of a layered restoration, even when you're doing an indirect restoration or a cusp replacing restoration.
Yeah, let's just say every biomimetic restoration has a direct component.
So even if you are doing a lot of CEREC restorations, you need to understand lesson 4 to make your biobase and also your margin elevation as highly bondable as possible. And so the idea of a margin elevation or raising the box, we are restoring deep boxes directly in low C factor layers. And these layers are done in horizontal 1 millimeter increments. And by modifying a Tafelmeyer allows you to get past the height of contour of the adjacent teeth and really get some good apical constriction without the use of wedging, which can slip up and over your margin if you're not careful. And so my favorite is the Garrison real tight margin elevation band. And if you are patient with it, you can have some very, very dramatic results without the need of crown lengthening, and also an additional matrix in some instances. But you can see this premolar on the left, highly carious, subgingival. We create our peripheral seal zone. We stop at our measurements, and by understanding the hierarchy of bondability, we actually know the bond strength of the gingival floor, the axial wall, and the pulpal floor. And you can see the radiograph on the left and the radiograph on the right. A very, very biomimetic outcome on a very difficult tooth that most dentists would say needed to have a root canal, and
condemn that tooth to be lost in the lifetime of the patient.
Yep. So when we restore these boxes, we will use a low C factor layering, and also we'll try and delay the gel point with a slow start photoactivation. This gives the bonded dentin a head start with very minimal stress, while the onlay is being fabricated either chairside or indirectly. So the benefits of a margin elevation is you can actually mimic the tooth, because a tooth has a gradient of flexibility. So you have a margin elevation should have progressive flexibility, preserves maximum tooth structure and hard tissue, and relocates the margin supragingival. And this was first introduced by Didier Dici in 1998 with Roberto Sprefico. And the idea is we want to match the different areas of the tooth and have a progressive flexibility, because if we have a mismatch of deep dentin with a very stiff ceramic in a box, we can have some bond fatigue as the tooth is under function. But over the last 5 years in particular, we've had some very important papers that have shown that with deep margin elevation, there is very minimal periodontal complications with these techniques when they are done correctly under good isolation and biomimetic protocols. So lesson 5 is the adhesive prep design and bonding to enamel. The first thing we need to do is, when do we onlay a cusp? The idea that a tension cusp is more likely to have cracks and fractures into dentin. And so 80% of cracks occur on buccal cusps of uppers and lingual cusps of lowers. So this acronym of bull, buccal of upper, lingual of lower, that's where you will find most of your cracks into dentin when they are going obliquely. And this is because these cusps have no cusp-fossa relationship. So we will onlay cusps that are less than 3 on tension cusps. and we will preserve holding cusps that are greater than 2 millimeters. So a holding cusp, we can get away with a thinner cusp, whereas a tension cusp, it is better to onlay maybe a little thicker cusp because it doesn't have that cusp fossa relationship. These preps should be relatively flat. And when we were talking about relatively flat, we still want to preserve thick cusp because thick cusp contribute to fracture resistance of the tooth. So when we look at a tooth, we diagnose based off of a 1, 2, 3, 4 model, and we talk about this a lot in lesson 2. But the first thing we do is we look for one crack into dentin. We would look at the peripheral rim fractures, and based off of the size of the restoration, which would be number 2, which would be our isthmus width, and 3, which is our cusp thickness, and then 4, our box depth, we can assess that this tooth is not bending and flexing in a biomimetic way. And we can see that when we look and assess the tooth structure. These tension cusps are less than 3 millimeters. This holding cusp is less than 2 millimeters. And sure enough, when we take out the restoration, we can see occlusal effect carries along the fracture and the fracture running along the tension cusps. And so what we do is when we identify that fracture, we actually go ahead and remove this with a round diamond. And this is our preparation. So we have crack removal while preserving a holding cusp. And there's a variety of reasons to preserve this holding cusp, especially if you were choosing to use a composite onlay material rather than a ceramic. But every biomimetic restoration begins with a caries removal endpoint, then goes on to immediate dent sealing and resin coating, and then finally a cementation of our onlay with heated composite in combination with air abrasion.
You might say that the BioBase is the dentin replacement.
Yeah, so this is what we're talking about, the BioBase,
That has dentin replacement.
and it has a composite that mimics the modulus of elasticity of dentin. These restorations can be done chairside with a semi-direct composite restoration. It's just one strategy. If you prefer ceramic, by all means, you can do biomimetic restorations with ceramic, composite, and even gold when you understand the principles that we've discussed in these first 5 lessons. So this is the semi-direct composite that I made a couple years ago while in the Army. You can see a structurally compromised tooth with fractures. These fractures here stop at the DEJ, whereas the distal crack went into dentin and we removed that crack. Here is our BioBase with the dentin replacement, making the onlay, and then cementing that with heated composite. And then finally, lesson 6, which is occlusion. We will just touch on this very briefly, a trick on how to capture your non-working interferences. But mainly, the main complaint of a patient is that the restoration feels high. This is the most common source of post-operative chewing sensitivity. This can feel like a cracked tooth if the patient ignores a high tooth. So it's really important to say, hey, if this bite doesn't feel quite right when the numbness wears off, we need to do some adjusting without anesthesia. And so the first thing you do is you just check your normal working interferences where they're chewing on a single piece of paper. Remove the sliding contacts. And then we will widen the fossa and narrow the cusp to eliminate these lateral slides. And this helps to to verticalize the occlusion. We want to make sure that the contacts are equal on the adjacent teeth. So with working side interferences, the treatment is to widen the fossa or narrow cusp to eliminate lateral slides. And we want the vertical cusp fossa contacts equal on adjacent teeth. And then with the only exception on non-working side interference, you want to keep the condyle from scraping the medial wall of the fossa. But when we are checking for the non-working interferences, this is a trick that my father learned from Gary Unterbrink, and he taught me. And I don't know if I've seen anybody else do anything similar. But it's really important that after you've checked your working interference, that we also remove these non-working interferences. And the only way to pick up these non-working interferences is to actually have the patient chew on something on the opposite side. And so what you will do is you'll do your working interferences where they're chewing on a single piece of paper. And then you will take a tray holder and you'll put 2 pieces of articulating paper, and you will have the patient chew on the single paper on the side that's not numb, and have her keep or he chewing on that opposite side. And then while they're chewing on that, you will slip the double-sided paper on the side that you restored. And while they're chewing on the left side or on the right side, you will actually pick up these non-working interferences. And so with the non-working interferences, you would want to eliminate these contacts and the best way to pick these up is with a double thickness occlusal indicating paper. So remove non-working side interferences. And the only possible exception is with a painful joint that needs support from that contact. And it's important to repeat this. And if you can do that when the patient is not under anesthesia, you will have a much more accurate bite. But if you bring the patient back the following day, that's also a good time to get a final polish. And you can use whatever system you like. And so the biomimetic number, after you've gone through and mastered the science that we have just briefly touched on, should be 0. In other words, the number of teeth that you cut down for crowns in the following month after being trained should approach this number of 0 full coverage mechanically retained restorations. And so if you have questions, we would encourage you to schedule a jumpstart call with either myself or my dad to talk about possible mastership opportunities. And you can also reach out to us through our Instagram accounts.
Awesome.
So really appreciate you having us.
Absolute pleasure. It's been really fantastic. There's a lot of things that I think all of us have taken away from, and there's definitely a lot of questions in regards to certain bonding systems, cracks, and I really like the kind of, as you mentioned, the bottom down approach. And quote unquote, I'm going to use crack-free situations. That's something I've definitely taken away from what you've said today. So we'll talk a little bit about, and I'll get Kane on in a second. We'll go into the Q&A shortly after. But a few questions and I'll give you a bit of a heads up, is, what extent do we remove cracks that are potentially interdentine or subgingivally? Where do you make those clinical decisions? And there'll be a few questions about what you're looking for in terms of flowable materials and that resin coat when using kind of SE bonds. And we may not have we do have SE prime and bond in Australia, but we may not have the same flowable. So again, I'll ask a few questions about that in a moment. Again, we're really fortunate to be sponsored by Mordent. And we've got Kane right here, where you able to use the sponsorship to also donate to hospitals and medical healthcare workers in Australia who are on the front lines and doing kind of their bit for us. So we're really, really grateful. Davey, is it okay if we just grab, yep, perfect. What we'll do is we'll get into a bit of a questionnaire with Kane. Both Doctors Davey and David, feel free to have a little rest. We'll get you guys back on in a moment. With Kane and Mordent, we've spoken about them before, how they can help you get into implants and what the Mordent service provides. And what we've had amazing experience with is the level of service and kind of getting into helping you with your questions that you may have. So Kane, there's a bit of a rapid fire. We'll get into it. One of the things Daniel and I talked about last time was how to get into implants. For listeners who are looking to get started, not sure where to begin, what do you suggest?
All right, that's a good question. I think every dentist, especially those new to implants, need to ask themselves a few questions before they register for courses, right? Like, what is the feedback from other attendees? Has the course provider got a track record of training and supporting other successful implant practices? Is the curriculum strong, like both academically and practically? Most importantly, is the course run by experienced clinicians, including specialists, and is there mentorship available? Because that's critical too. Additional things would be around the support team, what workflow and solutions that might be provided to help you with what you've learned.
That's really good. So if someone doesn't have much experience, is there somewhere that Mordent can help in particular way? Is there kind of a place to start for someone who really has no information and maybe doesn't have guidance in their clinic?
Cool. All right. Well, without sort of trying to sound like an infomercial, I'm pretty proud to say that at Mordent, over the last 15 years, we've provided training to over 3,000 Australian dentists. So, and more importantly, walk with them through the process as their confidence and implant businesses have grown. So we'll have been closely involved with, I'd say hundreds of thousands of cases, and like any good business, ours to a very large degree is grown on the basis of referral. And I reckon that myself or any of our territory managers around the country would be able to call on clients in pretty much any suburb to endorse their the learning and implantology journey with us.
Do you have an example of someone who's maybe other than myself, or an experience of where maybe a lot of young dentists struggle with initially, and where kind of Mordent can help them out, where maybe others, to prevent the mistakes that a lot of people do make in their early implantology? Cool.
Well, course-wise, the first step of what we offer, and where anyone really should start, is a basic implantology course, right? We run this through our Dental Implant Academy. It's run in 5 states on a regular basis, and we've teamed up with leading specialists, experienced GPs. We deliver a 2-day weekend course that delivers everything, all of the key implantology concepts, so surgical, restorative, hands-on, and at the completion, and sort of to answer your question, I think it will give clinicians the opportunity to confidently start discussing and undertaking implants as a treatment option with your patients. But the curriculum's scientifically based, but also very practical, including hands-on exercises and full coverage of things like digital technology as well.
Yeah. Look, I think like a weekend course for someone who has no experience is a great place to start, because it just opens you up to what is out there. It's definitely maybe not the end of your journey, but it can definitely be a start. And it's also an affordable way for a lot of people to get an idea of the systems and what's out there and what's available. And also you figure out a little bit of your own, deficiencies and what more information you need to know to kind of continue going there. Yeah. I've been very fortunate in terms of having kind of more senior clinicians around me and things like that. And, having Mordent there, and, I can vouch for, Kane coming into my first case, having, a little pointer out there, making sure that, you're using the right drills and using the right system, because each system is different and you've got to know the protocols really well. And it just gives you that confidence. Is that something you provide to all kind of young dentists who wish to use your services, or,
Yeah, for sure.
And is there a cost to that?
I think we've built our business on that type of support. Look, the journey definitely doesn't end after you do a 2-day course. I mean, that's kind of just the beginning. So what's important, I think, is to know that once clinicians go to our courses and have attended them, they have the full support of our fairly extensive team of mentor clinicians. So this includes specialists, experienced implant dentists in each state. I think we're probably the only implant company to have a full-time implant specialist dentist as our clinical director. So with his support, we have a team of planners, with science and anatomy background, as well as prosthetists, dental technicians, to assist you to plan your cases restoratively, so you can have a great outcome for your patient. So you've been, Alex, to our head office in St Kilda Road in Melbourne. We also have a 3D printing and milling centre for surgical guides, restorative crowns, and as you said, we've got consultants in each state, including myself, to come and assist you in person with your surgical and restorative cases. So suffice to say, and I think it's really, really important, someone will be by your side every step of the way. And it's the difference between just doing a course and actually getting started.
Absolutely. Yeah. I've seen the facilities. They're pretty incredible. And you have that support from implant placement to the restorative and, senior technicians who've done much more complex cases than whatever your first case is going to be. So you have confidence in kind of in their experience and their ability. For those who kind of start there, what's the journey afterwards? What other courses, or what's usually the system?
Cool. All right. So there are a lot of courses following on from the basic implantology course. As I said, the mentorship is, I think, probably the most important part of it. But if implants is something you really want to properly get into, we have courses and curriculum that follow on from that. We offer, for example, an implantology fellowship program in conjunction with the University of Miami and other leading universities, where, amongst other things, you get to do one-on-one university-based live surgical training, where you're planning and performing implant cases under the full-time guidance of a specialist mentor. So that is a progressive step, but a really wonderful sort of next step for clinicians who want to really get into it.
Absolutely. And, for people right now, we're stuck in this COVID environment. Everyone's online. We're hopefully slowly getting out there into the real world. What can people do now over the next, let's say, few months to get themselves, to make the most out of, or get the most value out of potentially courses they might sign up to later?
Yeah. Hands-on courses, our overseas courses, they're all cut at the minute, but look, just jump on our Mordent website. It's mordent.com.au under education, or you can go directly through Dental Implantology Academy. Drop us an email at academy@mordent.com.au, or even someone in our team. Just simply Google Mordent, have a look at the courses. We're also offering, as in preparing for your year, but we're also offering online basic implantology programs. So anyone who's interested, get in touch with us and get started.
All right, fantastic. Thank you, Kane. So Kane's the kind of sales manager for all of Mordent, and really is the main go-to, but he's also the Victorian rep. There are reps in every state. So hopefully we'll have more people from Mordent so that you guys get a bit more experience and exposure to them, so that when you do get in touch, you know exactly who you're getting in touch with. So thank you so much, Kane. We'll bring Dr. Davey and David Alleman back with us. How are you guys? Thank you so much again. It's been...
Hey, you're welcome.
Still awake.
Absolute pleasure. I think Daniel's coming on board. He's got his mic going. Yeah, absolutely. I was going to say, I know you've been super excited, and so I'll let you lead the Q&A on this one and get all the questions you wanted answered as well.
Yeah, excellent. Well, look, I think a good place to start actually, because, our audience in general, we do have a lot of younger dentists on here. And one of their main questions is that they're working in clinics where maybe their boss is a bit more traditional. And one question they have is how they can go about explaining this to their boss, who maybe tells them that placing a margin, you should always place it on tooth, and that, porcelain is the best, and they've just been brought up a certain way. And I suppose the best way to broach that, maybe beyond telling them to sign up to your mastership.
That would be the best. But there are some available resources for young dentists to get the literature. One is the Biomimetic Study Club from Jeff Davies. You can go online and find the article that Davey and myself and Matt Najad wrote in 2017, which has the protocols. And then it's important to know that there are hundreds of dentists that Pascal Magne, myself, other trainers like Marco Gresnik and Dave Gerdol and Didier Dici. So there's a dozen really um, highly biomimetic programs that teach dentists around the world. And so there's thousands of dentists that are doing this, and it just takes time to make changes. The last major change was over 100 years ago. So before the turn of the century, extractions were the standard for any teeth. And that's why my uh, designation as a doctor is a doctor of dental surgery. Davey's designation is a doctor of dental medicine. The idea of healing a tooth, even amalgam, had the potential to heal a tooth. The tooth would heal itself. Oftentimes it was successful. When it wasn't, then traditional surgeons would say, see, you shouldn't have tried to put an amalgam in that tooth. But we know now that the success of biomimetic dentistry is so great because we have a network of about 300 doctors that report to us. Pascal has about the same, maybe a few more international doctors, but we estimate there's someplace between 1 and 2 million teeth that have been treated biomimedically instead of traditional crowns or traditional crowns and buildups. And with a number of 2 million, then it becomes very obvious that the traditional dental schools need to change. And there are 5 dental schools in the world that have changed. The first one was University of Geneva in Switzerland. The second one I would say is University of Southern California in where Pascal Magne teaches in Los Angeles. The third I would say is Groningen University in Holland. The fourth is the Universidad de Portales, Diego Portales in Santiago, Chile. And then the fifth school I would say is University of Washington, but they haven't trained their undergraduates, but they have faculty members. There's probably 7 or 8 doctors, faculty members of schools around the world that are highly trained. It's moving in that direction, but University of Geneva has been doing this since the early 2000s exclusively.
Yeah, the main thing is if you are a young dentist and you want to challenge someone that you're working with, the thing you need to do is you need to know the science so good that when they call you out on it, that you can actually back it up with 2 or 3 pieces of literature. The second thing you need to do is you need to invest in photography so you can show the high level of dentistry that you are performing on a daily basis that's, being overlooked. And if you can show those 2 things, then typically they will probably not call you out in the future. When I was in the Army, I had those same fights. My first 6 months was not fun, but luckily I had the literature down. And because I kept getting called out, it caused me to actually start to document my cases. And it started with just my camera phone. But eventually my boss was like, well, it's not worth picking a fight with Captain Alleman because he's just that big of a, knothead.
Too stubborn.
The reality right now, you have that resource of Davey on his Instagram account. The whole world can see 2,000 photographs documenting 375 cases. And each of those cases have the step-by-step procedures of the 6 lessons. Mm-hmm. Now, a doctor that hasn't had training won't exactly know what they're seeing, but for sure they won't see any Theracal on direct pulp caps. There won't be any MTA on direct pulp caps because Pascal and I showed the world how to not expose a pulp. That's by measuring how deep you are into the tooth. If you stop at 5 millimeters going axially and 3 millimeters going, 5 millimeters from the occlusal
and 3 millimeters
towards the axial, 3 millimeters the axial. If you stop there, the pulp doesn't live in that portion of the tooth. You will not expose the tooth. You reduce endo by 300%.
Yeah, we didn't have time to go into the papers that really showed the microtensile bond strength to inner caries and outer caries.
Or it's all science. It's all there.
I was going to say something that you mentioned was, leaving that affected dentine or the caries closer to the pulp to, obviously prevent pulp exposures.
Yeah.
You mentioned something about leaving it, or something you mentioned about to allow it to strengthen the bond. And there was also a question about potentially, there being a radiolucency on a post-op bite wing. And is that something to be concerned about, or how do you communicate and ensure, other clinicians aren't looking at your work and,
you're not going to see that much shadowing under your restorations, even if you are leaving quite a bit of the red stain. I mean, you saw that extreme case on that bicuspid.
Mhm.
The only time that you will see radiolucency typically is if the SC bond gets a little thick under that. But you can distinguish that very, very easily because it's very uniform as far as like
quite a uniform gradient line.
But you can have a little bit of a radiolucency if you don't have a very clean peripheral seal. But if you're using the caries indicating dye and using a very very radio opaque material with like the Curare materials, I just haven't seen radiolucency.
20 years ago, we didn't have these materials, and we would see that. And occasionally, a dentist would diagnose recurrent decay under a restoration. Then we took it out. It wasn't recurrent decay. It was remineralized. Mm-hmm. Quite often in a deep area, it'll actually go from a radiolucent line to a more radio opaque line at about 12 months because you do have remineralization in a vital tooth.
So it's always good to take a post-op x-ray on any of these deep restorations, whether it's direct or indirect. And that way you can kind of have a baseline to check.
Yeah. Absolutely.
I was going to say, Alex has got lots of technical questions, I think, which we might dig into. But just before we do, the other thing that I think a lot of the listeners out there are interested in is not only knowing, I guess, how to broach this topic with their boss potentially as associate dentist, but with their patients. Is this something that you're actively discussing with your patients, or it's just one of those aspects of dentistry that is sort of swept under the rug?
What we say is you can get this tooth fixed possibly once, and it's a little bit more expensive with us. But the benefits is we can preserve way more tooth structure and possibly eliminate the need for root canal therapy that other dentists are, sending these teeth without even giving the tooth a chance. And so, taking photography helps in explaining the differences in the process of fixing these teeth. I mean, one of our associates, that Marco Gresnit, he has a nice sign in his dentist that says "slow dentist," and so that's something that you shouldn't necessarily say with a lot of if you feel like embarrassed by as a young dentist. It's something you should actually be very, very proud, because Marco Gresnit is one of the best researchers and clinicians in the world. And if he's okay with calling himself a slow dentist, then, why can't I also consider myself?
Yeah, Davey's brother-in-law, my son-in-law, is a neurosurgeon. Would you want a neurosurgeon to be in a hurry so he could get to the next case? We'll just leave a little of the tumor. It doesn't, no. It's like sometimes you have to leave some of the tumor so you don't kill the patient. But you have to make those decisions with the system.
I might follow on that. In terms of terminology, do you define what you do? Do you call it a biomimetic crown? Do you call it an onlay as opposed to a crown? Is there certain?
It depends on if you're probably just the demographic of your patients. So in this office, we don't call it a crown. I work a day and a half at another office, and they do everything biomimedically, but they call everything a buildup in a crown. And I mean,
They
it's
have insurance
it's
issues.
Yeah, it's an
for
insurance.
insurance, but the problem is if those guys go to another dentist and they think, well, he said I needed a crown, so what's the difference? This guy's in my neighborhood, I trust them as well, and he says I also need a crown, but it's two different
Absolutely. Yeah.
restorations. And so I would like them to kind of get away from that terminology, just so they can distinguish, so the patient has some kind of reference to distinguish that, hey, this is
not
where I should
traditional.
continue to be treated and not,
What we do in our office, because I've been doing this for over 20 years, we just put a lifetime guarantee. We say, if you have a chip on this tooth, we fix it for free forever. So far, we haven't had to ever replace from the bottom. In other words, no recurrent decay, no fracture underneath the restoration. We get a chip on the top, the enamel replacement. You can bond that on without anesthesia. It takes 15 minutes, you're good to go. But a very small percentage of those. But no, one doctor I trained 12 years ago, that's the office that Davey works in, a day and a half a week. He's done 10,000 biobases and has not had recurrent decay underneath any of them. Now, you can't do 10,000 crowns without over 12-year, 13-year period and not have some
recurrent
decay on under crowns. Ooh.
Wow, that's I think that's going to be really helpful.
Mic drop moment there.
We have to digest. Excellent, Alex. What else have we got there?
I'll go through a couple little more little questions. Sure. One question I thought was quite interesting was, and I've seen a couple cases where we won't go into terms like hierodontics and non-hierodontics, but if you have cracks that are extending into dentine, potentially subgingivally, where do you make the decision on?
It's just like a decay. So you have a peripheral seal zone, you go crack free. The only modification is that when you go deep in caries or deep in a crack, sometimes you'll have a little shell of the root that still has a crack in it in the cervical area, but you'll keep that just to maintain isolation from your periodontal tissues. But you dissect the crack going down the side of the root in that 2 millimeter area, 360 degrees. If the crack goes deeper than 3 and deeper than 5, you stop. And so that's the area where the pulp doesn't support, a natural pulp does not support a tooth side to side, front to back, and top to bottom, deeper than 5, deeper than 3. So you have a 360 degree peripheral seal zone that's free of decay and free of cracks. Right. And we've done those to 9 millimeters from the marginal ridge. So, but that's where a microscope or 6 times or 8 times magnification really helps. Very, very, very helpful. And we recommend that all the paper that Pascal and I wrote in 2012, we recommended 6.5 to 8 power magnification. And that's, like I say, if you're a brain surgeon 100 years ago, you never had a microscope. If you try to do brain surgery today without a microscope, that's malpractice. And we're working on the largest cranial nerve, the trigeminal nerve. So we're kind of doing brain surgery. So I'd say magnification is the way to go. I've been using a microscope for over 20 years.
Yeah. Wow. Definitely something all of us wish to do. Daniel's about to open his practice and he's invested in a microscope because
it's the first thing I bought.
That's good. That's good.
Definitely something.
Go through the learning curve sooner rather than later.
He's been working with one for a little while. I'll ask another couple of questions. If someone's getting planned for a denture and you have a large restoration, semi-indirect or indirect, whatever it may be, are there certain modifications that you're doing in terms of the restoration in order to allow for, I guess, a better abutment? And a second part to that is if you have a tooth where you are looking at preserving tooth structures, but patients have buccal abrasion lesions and they want those restored for aesthetic purposes, where are you making that compromise? I know these are a little bit different questions, but maybe
that makes sense.
So if there was 2 different lesions, a top problem and a buccal lesion, as long as it's not in an aesthetic area, I would say treat them as 2 separate lesions. The only A possible exception is on certain bicuspids where I would kind of do a veneer lay, but I try not to violate that biorim if there's just an abfraction or a class 5 lesion, and that's just because when the tooth is being under function, the forces are always transmitted to that margin.
Right. And in regards to the survey crowns for dentures, I mean, it was a question asked, but there's nothing particularly different from my understanding that you would do.
I've never done a partial.
Wow. What happens?
I mean, in the Army, most of the guys were young and they still
That's
had
what prosthodontists
still
are
had
for.
teeth.
Yeah.
So I've got my surveyor from school. I think it's just a paperweight right now.
Every dental student's dream, I think, never to do a denture after graduating.
Yeah, so I've done one denture to graduate dental school, and
we mentioned a little bit of science. Is there a particular resin, composite resin, that you prefer to use for deep margin elevation and that biopace? Is there a particular reason? And again, just more principles in terms of nano hybrids and filler, because again, different products on the market here. Just for, again, to give the viewers a bit of a guide into maybe what they should be looking into.
So what we actually prefer is a hybrid composite. It's a very old composite. It's called APX from Curare. It has a shrinkage of less than 3, but the modulus of elasticity is 16.7. So it's just right in the perfect intermediary zone of dentin. And so if deep dentin is my alarm just went off.
You're waking up right now. Yeah, so the research showed the best results when the modulus of elasticity of the composite in the marginal elevation was at least 9. If you get less than 9, then there's too much flexibility. If you get more than 15, then it's too stiff. So ceramic at 60 gigapascals for the modulus of elasticity. The worst thing you can do is to try to put a deep box ceramic into that cervical area. You'll get a debond very, very quickly. So the idea of a gradient, if you start at something around 9, which would be like tetric flow, which was the original tested material, and now we use a 12 gigapascal modulus of elasticity called Majesty Flow. And I do believe that Boko has a similar material now. They've kind of reverse engineered that from the Japanese. If you can get something for your flowable layer between 9 and 12 gigapascals, and then get your composite someplace in that 12 to 18 range for that margin elevation to get it super gingival. That's the biomechanical match in a biomimetic restoration for a deep margin elevation.
For a margin elevation, do not use a resin modified glass ionomer or glass ionomer, or don't use don't just use bulk fill or just a flowable for your margin elevation. It's very important that you keep that flow very thin, and then do thin layers of your restorative composite for your margin elevation.
I think that's quite key. I think a lot of people know certain principles of deep margin elevation, but maybe don't apply, the restorative aspects.
Each of these steps, have multiple tests that have been done and developed over 20 years. So there's a history and an evolution. Just about anything that any dentist that's listening to this might think, well, maybe I would try. It's all been tried. It's all been done. Don't try to reinvent the wheel. This has been evolving over 20 years. If you read the literature and you follow the clinicians that follow the literature, you'll do the right thing at the right time. But you do need training.
Yeah, absolutely. And I think, for those just getting out there, is there something that you would recommend? Obviously, I think, reading a bit of the literature, maybe we'll get we've mentioned a few references out there, so maybe get a few links for those involved. Is there some way, I guess a question for young associates out there, how would you advise them to approach their senior clinicians, principals, owners of getting into this kind of dentistry? Obviously, a lot of money conscious and price conscious and business conscious. Is there a way that you would recommend for them to?
I would recommend make sure you work for somebody who really has the best interests of the patient at heart.
That helps.
If the business owner thinks that doing a root canal is just a moneymaker, try to go someplace else, because your patient does not want a root canal. If you can prevent it, they don't want it, and they don't want their tooth to be 50% destroyed or 70% destroyed either. Patients aren't stupid; they know what a crown is. Intuitively, it's like, you're amputating my tooth so that you can put on a prosthetic. Wouldn't it be better? I've got an ingrown toenail. Let's just
Cut off my toe.
let's treat the toenail, not cut off my toe.
Yeah.
Makes sense.
Yeah. There is a doctor in our June mastership group who was in such a bad situation that they disallowed him to use a rubber dam because it took too much time.
Too much time, and they wouldn't let him use an isolite because it would cost $1, or the Mr. Thirsty, kind of a.
But anyway, he had to break. It was so bad he ended up leaving this this corporate
contract
chain, and he got sued by them for breach of contract, and
he sued them for being incompetent.
So it just got him. It just took him.
But he's out now, so
he's out of it. But it cost him just only $100,000 to.
But I would say that every doctor who's listening to this, doesn't matter how young you are, you're a doctor. In other words, the patient has confidence in you, and the Hippocratic Oath says, do no harm. And if your goal is to do the best and to not do harm, even if you're just learning this from Instagram accounts, and you have a vision that this is scientifically based, which it is. If you go to my Instagram account, I've listed about 70 articles. In our mastership program, we go through about 130. If you're going to teach it like Davey, you've got to master a Matt Najad, you've got to master about 200. But this is selected out of 2,000 that I've been reviewing over the last 25 years. And those 2,000 articles aren't just like comic books. This is like 4 years of somebody's life to write one paper.
Absolutely.
It's a PhD. I mean, if you don't believe in science, I get it. Just do whatever. But it's like, that's not what your patients think a doctor is. A doctor has a responsibility to do the best possible based on the current science and evolution. And if a doctor who owns the practice is not current because he thinks amalgams are great and crowns are great and root canals are great, and he's okay with 13% failure. You do 100 teeth and 13 of them are lost, or 13 of them have to be retreated in a more aggressive way. Well, if you're the 87%, the patients think, oh, my crown is fine. But if you're the 13% where the crown is lost or has to have an endo or has to be retreated, costs you more money, you're thinking, man, I wish dentistry was better. I mean, this is the world we live in, and the responsibility, if you have integrity, it might not make you as rich as fast as somebody else, but it's like you can sleep at night. Absolutely. And you can look at the patient in your eye and say, I'm doing my best.
Totally understand. I think it's something that we all have to kind of ask ourselves and make our own decisions and do our own readings and learnings and create an ethos that we can sleep well with and feel comfortable and treat patients the best way. Absolutely. Daniel, do you have any last questions to round off, or?
No, I think, look, there's a couple more that we'll try and direct people your way to answer in the future. Definitely, we'll still be in touch with everyone with maybe a few links to some of those articles, as well as if you do download that pre-worksheet, you'll have all the details to get in touch with David and Davey, and check out their mastership. And we've been having a blast with the Allemans tonight, and in general with everyone here joining us on this webinar series. So thank you very much for everyone for joining, and most importantly, thank you to the Allemans for staying up till, gosh, it must be coming on for 5 a.m.
Hey, it's
5:30.
Yeah, quick nap, or is it breakfast time?
We're gonna watch the Michael Jordan special that's just published by ESPN, called The Last Dance, where Utah got beat.
Right.
You guys might be too young to remember.
You don't
that,
remember this.
That's it.
Michael Jordan and Karl Malone, John Stockton. We didn't win those twice. They got us twice, and
Damn.
it was heartbreaking for us.
I think we have that.
1997. How old were you, Davey? 12?
12, yeah.
12 years old. Davey was heartbroken. It was like, but we made it to the finals. So that's a lot of teams never even make it to the finals. So we have something to.
Yeah, we actually got an Australian on the Jazz right now, Joe Ingles.
Joe Ingles, you know Joe Ingles? So we have an Australian.
Not a follower,
I have a few people who I work with who would be biting my ear off right now.
Yeah, everyone on the comments must be screaming right now.
Once again, guys, thank you so
European
much.
doctors, and they follow basketball. A couple of really awesome.
Thank you again so much.
Hey, you're welcome.
We'll
Thank
see
you.
ya.
Yeah, we'll be in touch. Thanks, guys.
Thanks, everyone.
No worries.
Bonded.
Yep.
Take care.
This is you ending fire, then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, holding out, Father, oh, prepare as we will watch the flames burn over on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees, and I see fire hollow and soul. I see fire burning the breeze. If I hope that you remember me. Surely I'll do the same. Confined in mountain holes, we got too close to the flame. Calling out, Father, oh, hold fast and we will watch the flames burn over on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire. is to end in fire. Then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over and on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, calling out, Father, oh, prepare as we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees.